Now I'd like to speak to you about venomous bites and stings. So, what's the most common bite in the U.S.? Dog. Absolutely, dog. All right. So dogs, in addition to having a lot of bacteria on their teeth, they also cause a ripping and making many jagged wounds. And it's a tearing kind of injury. And their jaws are quite strong in the larger breeds, so that you have crush injury and devitalized tissue as well. So this has implications for treatment because when you repair the wound, you want to remove any crushed or damaged tissue that's non-viable, and you need to close the wound in such a way where you don't leave any dead space where fluid and serum can accumulate to act as a culture for the bacteria. Cats, on the other hand, don't have ripping or tearing teeth and jaws, and they don't cause crush injuries of tissue. However, their teeth are like little tiny dirty needles that inject bacteria into the tissue. And the problem with cat bites is that you can't irrigate these cat's saliva away because it's just a little tiny puncture wound and you can't irrigate the area that's been contaminated with cat saliva. Cat and dog bites cause more problems in very young and very old patients. That's not surprising. They cause more complications in patients who delay in coming in for treatment. They cause more complications in patients who have a peripheral vascular disease. Because as you can imagine, most of these injuries are hands and feet, and if you don't have good blood circulation, good blood supply, you're less like your wound healing is delayed. So what are the germs? What are the pathogens? All right, it's polymicrobial. It's polymicrobial. There's multiple bugs in cat and dog saliva. All right, Staphylococcus, Streptococcus, anaerobes, Bacteroides. The one word I want you to recognize for cat and dog bites is Pasteurella. Okay, Pasteurella causes infection in approximately 24 hours after exposure. So if you just scrape your arm on the sidewalk and have a staph or strep cellulitis, that takes 4 or 5 days to get started to have a clinical cellulitis. Pasteurella causes clinical infection in about a day. So if they're going to get infected, it's pretty dramatic. It happens right away. Cats and dogs also have Eikenella, and there's some specialized species that just occur in cat and dog. In other words, what I'm getting at is when we are going to give prophylactic antibiotics for cat and dog bites, and we do need some very broad antibiotic coverage to cover all the different species of bacteria that are in the animals' mouths. The treatment for the dog or cat bite is to remove any dead tissue, okay? Look for any teeth in the wound, anything like that. Remove any foreign bodies. We want to irrigate the wound and physically flush away any dog or cat saliva. And then we want to repair the wound and wait for it to heal. So these all get prophylactic antibiotics unless the wound is completely trivial. I mean, if the dog didn't break the skin, you don't need antibiotics. But if the subcutaneous tissue is penetrated, I would have please give antibiotics. We treat these as infected from day one, from day zero. If you don't give antibiotics, at least 15-20% are going to have cellulitis and abscess formation. Okay? All right. A good choice is Augmentin, which is amoxicillin and clavulanic acid. And this will cover the Staphylococci and the Pasteurella. All right? So you're saying, gee, we're given pretty powerful antibiotics for this little innocuous cat bite. And the answer is yes, that's right. It's especially important because, the cats and dogs, they put little punctures over the hand. And that puncture might have hit the tendon or might have even penetrated the joint space. So if you don't treat this, a day later they're going to have a tendinitis or they're going to have a septic joint. And then they're going to need the hand surgeon to do surgery and open up this space with a very disfiguring operation to irrigate the pus away. Okay? What if the patient's allergic to penicillin? Well, you could use clindamycin and Cipro. You could use clindamycin and sulfa medication. Or you could use azithromycin. the key is we're using some pretty broad coverage here in each of these different scenarios. And the key is to try to convince the patient that it's really worthwhile to take these high-powered antibiotics when they just have this little puncture from the cat. All right. Now, humans are just as bad as animals, maybe worse, human bites, right? All right. You got your anaerobes, you got your Bacteroides, you got your aerobes, staph and strep, Iconella is in humans also. In addition, you have hepatitis B, can be transmitted through saliva. In addition, especially if there's blood in the person's mouth who you hit, you can get AIDS, HIV transmission. So post-exposure prophylaxis for HIV may also be indicated. Human bites are often on the ear or the nose or the tips of the extremities, and there's certain problems there. The ears have the cartilage, which are very easily infected. Okay. A lot of human bites are actually from the person that's injured hits someone in the face, on the teeth, and what happens is the tooth cuts on the knuckle and can damage into the joint space or just the tendon. So this is called a closed fist injury or a fight bite. And when you examine the patient, if you're examining their hand like this, you don't see the laceration of the tendon, because when they open their hand, the injured tendon retracts up into the palm. So if you have someone with an injury here that might be from a patient's tooth, also examine them with the closed fist, and you'll see exactly the track over the tooth made a little easier. All right, so here we go, a review. I should remind you that we do not need any cultures on day one. So even though we're treating animal bites that includes human bites with antibiotics on the day of presentation, we do not take cultures of the wound, okay? Because the recovery rate of bacteria is very low, but they're in there, all right? If someone comes to me 3 days after a bite injury, when it's obviously pussy, well then of course I take cultures. But if they come in right after the injury, the same day, I don't take cultures. You don't take cultures. So we're going to remove any teeth that are in there, any devitalized tissue. If the wound is less than 12 hours old, you can close it very loosely. And don't forget about tetanus shots. Don't forget about hepatitis B. Don't forget considering about HIV prophylaxis for if it's a human bite. And go again, give them a week's worth of antibiotics. Next, I'd like to speak to you about rabies. The treatment of rabies is all about post-exposure prophylaxis, because once you have the clinical syndrome of rabies, it's nearly 100% fatal. There's only scattered case reports of people surviving a clinical infection with rabies. What animals have rabies or carry rabies? Well, raccoons are a major reservoir, bats, wild dogs, woodchucks, skunks, foxes, cows even can have rabies. Squirrels and rabbits do not carry rabies. Bats are a major concern lately, that even exposure to bats' saliva being licked by a bat can transmit the disease. If there's any question about what animals are rabid in your area, you can always contact the Center for Disease Control and they'll help you. Domestic cats and dogs can become rabid, especially animals that are feral and don't have owners that aren't taking them to the vet getting the appropriate vaccines. When in doubt, this is a case where you need to err on the side of over-treating and giving post-exposure prophylaxis. That means after someone comes in and says, I think I've been injured or bit or licked by a rabid animal, you're going to give the medication long before they ever have the first symptom of rabies. Because once they have the first symptom of rabies, it's too late. The incubation can be up to a half a year. So a lot of folks that get rabies, they don't even remember the incident that transmitted the disease. Frequently, the patient will have a prodrome where they have paresthesias at wherever they were bitten. As you can imagine, this is usually the hands and the feet. They may also have fever. As the illness progresses, they have hypersalivation and lacrimation. They have muscle spasm and myoclonus. They have paralysis of the musculature controlling speech. Okay, not a very pleasant way to die. At this stage, you can prove the diagnosis from the clinical history and physical. You could also culture the virus from the saliva, from the CSF, and from the serum as well. If you do have a patient with clinical rabies, of course, supportive care, you do everything you can, prevent myoclonus with benzodiazepine as much as you can, and antiviral agents, ribavirin, has been used, and a patient has survived using ribavirin. But again, you don't want to wait for the clinical disease. You want to focus on the post-exposure prophylaxis. And here's what that is. Post-exposure prophylaxis consists of 2 different medications. All right? What you're going to do is give human rabies immune globulin, big HRIG, capital H-R-I-G. All right? Now, what the human rabies immune globulin does is it provides instant immunity the moment this stuff is in your body, right? It's antibodies to the rabies. So you get a shot of that. Actually, you can give, if the patient was bitten in an area that's fleshy, you can give half of the HRIG infiltrated around where the bite was, and the other half in a different site, like the deltoid or the buttock. If a patient was bitten in the finger, I can't give a shot in the finger pad, and then I would just give all of the HRIG in the deltoid or the buttock. The other medication you start, and that's just given, HRIG is just given on the first day they present to you for post-exposure prophylaxis. It's a one-time thing. The second medicine you give is the human diploid cell vaccine. Now, this is a total of 5 shots. The rabies shots are no more painful than any other shot you get. All right, you don't give them in the abdomen, and it's 0, 3, 7, 14, and 28 days. All right, and if you're giving the patient HRIG and the human diploid cell vaccine, you give them in different sites. For example, you give the HRIG in the buttock and the diploid cell vaccine in the arm. Okay. And that will prevent you from getting rabies after you've even been bitten by a rabid animal. All right, the snake bites. There's about 25 different species of poisonous snakes in North America, and you do not need to know their Latin names for the boards. All right, there's 2 general categories. You have your pit vipers, and that includes your rattlesnakes, your cottonmouths, and your copperheads. And you got your coral snakes, which are venomous as well. These animals cause very little tiny wounds with their fangs, right? But they kill from the neurotoxins, which cause neuromuscular blockade and respiratory failure, right? There's an old saying about coral snakes: red on yellow, kill a fellow; red on black, venom lack. You could tell if a coral snake is poisonous or not by the color of the snake. All right. So in addition to the neurotoxins, there's a complex brew of enzymes which basically dissolves your flesh. Proteolytic enzymes to aid in the spread of the neurotoxin and the cardiotoxins. There's toxins that lyse your blood cells as well, hemolysis toxins. Okay, so there's a cottonmouth for you. So it looks like he's on someone's front step there. Okay, here's a coral snake. Red on yellow, kill a fellow. So you see that the yellow bands are on either side of a red band. So that's a poisonous one. Red on yellow, kill a fellow. Red on black, venom lack. So here the black is on the red, so this guy is not poisonous. So it's always helpful if the people can bring the snakes in so you can see them. Envenomations is graded as mild, moderate, and severe. Occasionally you'll be bit by a poisonous snake, but they won't release any venom. That's called a dry bite, so now and then someone can be lucky. As you can imagine, most envenomations are the feet when you step on this animal, or by your hands when you reach under something you shouldn't be reaching under. A mild reaction consists of just local swelling and bruising, redness to the extremity that got bit. Okay? With a mild reaction, there's no systemic signs. It starts relatively quickly. You have a lot of pain in the extremity, but it's just the part that's bitten. Okay? Moderate envenomations includes symptoms, redness, swelling, discoloration, ecchymosis, bruising, all the way up the arm. It involves the entire extremity. And at this point, you have to start considering that the patient may develop compartment syndromes, where there'll be so much pressure in the compartments of the forearm or the leg that it'll cause pain, paresthesia, paralysis, pulselessness. Patients with moderate envenomations may have abnormal coagulation tests, abnormal coagulation profiles, but they will not have any clinical DIC or hypotension. Okay? They might be getting systemically ill, though. They might have some nausea and vomiting. Severe, as you would imply, is a life-threatening state with abnormalities of your hemodynamics, including low blood pressure, bleeding, elevated coags, and clinical bleeding at distant sites, such as GI bleeding from the bite. So what do you do if you get bit? Well, get away from the snake, right? Remain calm. You want to minimize the movement of the person who is bit to slow the spread of the toxins from the subcutaneous tissues around the body. Okay? Okay. Do you put on tourniquets? The answer for tourniquet is no. You do not cut off the venous supply to the extremity. You do not cut off the arterial supply to the extremity. Those are both wrong answers. Okay? You can take a little string and very gently, hardly ever compress the extremity to slow the return of lymph from the extremity to the central circulation. So no constricting band, maybe just a very loose constriction just to stop the lymph from flowing back. But it shouldn't be tight enough to impede venous return. Of course, the most important thing is to get on your cell phone and call for a helicopter if you're in the middle of the desert so they could take you to the nearest treatment center. Okay, we've all heard the rumor of you take the knife and you excise an X over the snake bite site and you suck out the poison. That's make-believe. That's not a right answer. Don't do that. Okay, no sucking out the poison. There's some other home remedies of shock and ice and all these things. Don't do any of those things. If you put ice on the injured extremity, you're just adding frostbite to the situation. You're not slowing down the envenomation at all. So, airway, breathing, circulation, airway, breathing, circulation. That's the first thing you do. And there is now an anti-venom which is used in both the pit vipers and the coral snakes. And these are used in moderate to severe envenomations and patients that develop the compartment syndrome from so much swelling and pressure inside a compartment of the arm or leg. Okay, and that works for rattlesnakes and the coral snakes, and that's called Crofab, C-R-O-F-A-B. All right, and there's a formula which you're not going to need to know for boards. You give the dose based on the size and weight of the patient. Okay, so Crofab would be the anti-venom. So if a patient just has a little bruising and swelling confined to the hand, I wouldn't give it. If it goes up the arm, and now the whole arm is involved, they're getting nauseous, they're getting vomiting, they may or may not have a compartment syndrome, I would go ahead and give the Crofab. If a patient presents with severe hypotension and clinical bleeding from low platelets, I certainly would give the Crofab. Well, thank you for spending this time with me. We've gone over a lot of emergency medicine, and you are now, knowing this material, well prepared to take your Step 2 CK. Thank you. It's been a pleasure.